My name is Naomi Elliott, and thank you very much for coming to this presentation. And I'm presenting this on behalf of Agnes, Higgins, and the whole of the research team. So this is a short presentation. We want to give you an overview of what the study was about and how we actually, what is the evidence and how we went about generating the evidence. I'm going to do the first bit, and then Agnes is going to come and talk about the actual key findings and, importantly, the recommendations, like we're here now and what is the next step and what's going to happen for the future. So I suppose by way of introduction, the actual background in terms of the literature and epilepsy research, many of you would be very familiar with this, but I suppose it's just to say in terms of the previous research and the research studies, many of these studies were carried out here in Ireland. I see Charlotte is here, and also in the UK. But what these studies did is that they actually identified a number of problems within the healthcare system and delivery of care that actually impact on the actual care of the person who has epilepsy and the overall delivery of those services. So these would be ones you would be very well familiar with in terms of the delays in accessing the specialist service, the lack of systematic follow-up, poor education of people with epilepsy and family members, the lack of communication between healthcare providers, the actual poor integration across the actual healthcare sectors. So these were in fact many of the common problems that we shared and experienced not only here in Ireland, but the research would also say in other countries such as the UK. So these in many ways would be the actual problems, and then what happens. In Ireland, I suppose in many ways you would be familiar with the recently launched model of care. And I suppose in many ways we actually have the benefit of having this particular strategic document, which gives very, very clear guidelines as to how the future model of care in epilepsy is going to be actually shaped. And it's actually very detailed to the point of how many numbers exactly are required for the whole of Ireland. So it's actually a very, very clear and important study, or I should say policy. The key elements of it really are it's aiming to improve access to expert care and information for people with epilepsy and their families and carers, to improve the quality of care across the healthcare spectrum, and finally, effectively, to try and reduce the burden in terms of financial burden and remove or move the actual care more to sort of community care settings. In other words, to be effective, and also to avoid people having to travel distances to avail of the specialist services. So there are, I suppose, the three key or core objectives of the actual policy. Key to all the delivery of this is the actual build-up of the numbers, building capacity, particularly in terms of providing access to the expert care. So the implementation of this policy is fantastic insofar as we're now seeing that it's already happening, and there's a build-up and there's a plan to build up the numbers of advanced nurse practitioners. And that they are key to the delivery of this policy. So this is not just a policy that's going to sit on somebody's bookshelf, it's actually a policy that's active and is being delivered on. The study, as the Minister said, is actually very timely, but it's particularly timely because in many ways advanced nurse practitioners have to be developed, and it takes time. So this study is very timely insofar as we'll see, and we've mapped out the evidence at this point in time, at the beginning of the implementation of this policy. And it's really important because it needs to guide then the actual rollout of the policy and the programme, and will guide what areas need to be highlighted. And Agnes will identify those particular areas at the end. Advanced practice, many of you will have met advanced practitioners, be they clinical nurse specialists or registered advanced nurse practitioners. But I suppose it's important to understand the context of the delivery of this programme within nursing level. In Ireland, there are two levels. There are the clinical nurse specialist and there are the registered advanced nurse practitioner. And the registered advanced nurse practitioner is a particular registration that is held by the Nursing and Midwifery Board of Ireland. So they register and accredit all advanced nurse practitioners. Within the world globally, the international developments of advanced practitioners is happening, but Ireland is relatively unique. It's not the only place, but it is unique insofar as these people are in fact registered, which is important because it gives a level of quality and assurance that all registered advanced practitioners meet the same criteria. The other important aspect there is the site preparation. And the Nursing and Midwifery Board are involved with the actual site preparation. And this is particularly important for the development of new epilepsy nurse specialists who are at advanced nurse practitioner, because it's a new role. It has expanded responsibilities in terms of scope of practice, and therefore, in order for them to be really effective, they need to be well integrated into the healthcare organisation and the actual services. So this process of setting up a new advanced practice role within a hospital or organisation involves the key stakeholders, the director of nursing, the medical consultants, everybody to come together to plan how this role is actually going to be delivered. Again, globally, this is in fact not carried out across in other countries. And in our SCAPE study, which we did an evaluation of advanced practice in Ireland before, that was one key findings, that is a strength of the process. Now, it's probably in many ways quite cumbersome if you're in the process of getting your site, etc., accredited. But the added value of that is that it means that your post is going to be more likely to be integrated and accepted, and therefore you'll be more effective in your role. The other important aspect is in relation to how nurses get registered as advanced nurse practitioners. They have to have a master's degree or even higher, and they also have to have a minimum of 7 years post-registration experience, which includes 5 years in this case would be epilepsy specialist. Again, this is a particular feature of registration requirements here in Ireland, and again, the added value of this is that these nurses, one of their key roles would be leadership. Now, if you don't know, if you haven't worked and you haven't got the organisational knowledge and expertise, and you are then expected to lead on development of new innovative services, this is why having that experience is so important. So you can see the preparation of the advanced nurse practitioner and the rollout and the delivery of the models of care policy is actually going to take time, and in many ways it's not a quick answer, it's not a quick fix, but it is a good investment, and the features that we have in terms of our registration positions us for sustainability of the actual programme. So what was the SENSE study? The SENSE study, we were tasked with identifying the scope and the role of the epilepsy nurse specialist. We know about epilepsy, or we know about nurse specialists in other areas, but we didn't know what were the unique and important features of the epilepsy nurse specialist, who were able to tailor and respond to the actual particular needs of the people with epilepsy. We also wanted to identify the impact of the epilepsy nurse specialist on the patient experiences, and thank you for sharing yours, because that's really important, and the quality of life. And finally, to appease the Minister and everybody else who has an actual budget, to actually look at the cost effectiveness of the role, which in today's world is also important. So how we went about it in terms of our study design, we used what we call a mixed method study design, but effectively there were 3 strands to this. The comparative survey asked people with epilepsy their experiences, so that was really an important aspect. The economic analysis also was carried out, and the case study, we wanted to understand how things worked, not just by doing a questionnaire and a survey, but we wanted to get a kind of a much more in-depth exploration and evaluation, hear people's voices in terms of the key stakeholders, and that was how we approached the actual evaluation. So it was as it were, a 3-strand approach. In terms of the data collection, the surveys really were given to people who were attending either epilepsy services without an epilepsy specialist nurse, and those with. So we almost had a direct comparison then of the impact of the epilepsy specialist nurse on the patient and their perception of the satisfaction of the care. In addition to that, we also did interviews, and the interviews were with the epilepsy nurse specialist and also the key stakeholders around the service delivery, the directors and acting directors of nursing, multidisciplinary team members who were directly involved with the epilepsy nurse specialist, people with epilepsy. Although we'd done the survey, we wanted to find out more their real experiences, which go beyond what you can capture in a questionnaire, and importantly, the family carers and family members and carers. So people sometimes say things, but we wanted to see, was it actually happening? So to that end, the epilepsy nurse specialists were observed as they were carrying out and as they were working in their clinical practice. So there were 61 hours of observation carried out, Agnes and Charlotte. So the other aspect in terms of the evidence that we gathered was the documentary evidence. So again, that's kind of the evidence. It's not being modified for research purposes. And we were looking at guidelines, policy development, because that's a key role of the epilepsy nurse specialist, which affects not only what they do, but also the multidisciplinary team. So the volume of data collected was far and wide. And we were able then to compare what one person said with the other person said, what we observed, the documentary, to actually collate and generate what we consider the evidence that we're going to present shortly. So the people who were involved in our study, we had 12 epilepsy specialist nurses, and you can see 2 of them were actually had reached the status of they were registered advanced nurse practitioners. 5 were candidates, so they are in the process of becoming registered advanced nurse practitioners, and 5 clinical nurse specialists. So here we can see the actual succession and how one develops the advanced nurse practitioner. And the clinical nurse specialists are important in that configuration. Not every clinical nurse specialist wants to go on to be an advanced practitioner, but equally you need to have that kind of succession to actually build up the advanced nurse practitioner. If you look at the professional qualifications, these nurses were highly qualified, not only in general nursing, but they also had the nurse prescribing registration course. They also had registrations in children's nursing and intellectual disability and in midwifery. Now, when you think in terms of services not being just in a general hospital, but reaching out to intellectual disability services, reaching out to the maternity services, that dual qualification adds an awful lot in terms of the quality. So it's important to understand that these epilepsy specialist nurses are highly qualified in terms of professional and also academic. 5 of them had their masters, and this is not just general masters, it's a master's in epilepsy, and 3 of them are actually completing their masters in epilepsy. So they have the clinical experience, they have the registration experience, and also they have the academic experience. And now I'm going to pass over to Agnes, who's going to present to you the actual findings.
Good morning, everybody, and you're very welcome. So as Naomi said, we had quite a vast range of data from a lot of stakeholders. And I suppose the first aspect in terms of when we analyse the data, it's important to recognise that in conjunction with the multidisciplinary team, the ASNs were providing care and support to people with epilepsy right across the age continuum, and some with very, very complex needs. They were looking after people with intellectual disability, people who had comorbid physical health problems, people with psychological health challenges and mental health issues, and not just related to epilepsy, but may have had mental health issues prior to epilepsy. They were responding to the needs of people who are living in care homes, and also responding to women in terms of maternity and pregnancy. They were also, I suppose, looking after, and I think it's important to recognise, and providing care to people who were at the pre-diagnosis phase and people who had long-term epilepsy, people that were free from seizures at that time are people with complex refractory epilepsy, or people who were experiencing non-epileptic type seizures. And they were also working with people who were pre-surgery for epilepsy and post-surgery for epilepsy. You might say, why am I telling you that? I suppose I'm telling it because I keep wanting to emphasise in terms of the level of knowledge and expertise that the clinicians had. And I think that that's important, and even in the rollout, in the configuration of advanced nurse practitioners and the discussions that's going on in the Department of Health at the moment, that in relation to advanced practice nursing, that we keep an eye and we emphasise that the level of expertise and knowledge that's required in the area, whether it's be in epilepsy or in another clinical area, because without it, when we look at the outcomes and some of the findings in this, you will see that people will be less effective. So in terms of the epilepsy nurse specialist, one of the first tasks was to look at the role. And when we looked at it and analysed the data, we could see there was three very big pieces to their role. One was the clinical aspect of the role, the evidence-based practice aspect, and the leadership aspect. The clinical aspect of the role was the largest, but the other two aspects in terms of the leadership and the evidence-based practice were critical, because without those elements, the quality of the clinical aspect would have been decreased. I suppose the clinical aspect of the role required a very high degree of epilepsy-specific knowledge and knowledge of the local and national services around epilepsy. It was underpinned by the principles of collaboration, empowerment and person-centred. And I think we have heard from Sinead and Joan this morning that the evidence of that, you know, the principles of collaboration, empowerment and person-centred care was underpinned the practice. Some key aspects of the clinical role included, I suppose, completing a comprehensive assessment. And, you know, we all hear about, you know, nurses being engaging in assessment, but I suppose in this case, the nurses were moving beyond kind of a disease model and incorporating the psychosocial dimensions of people's lives. They were looking at the impact of epilepsy on employment, education. They were looking at issues around substance misuse. So they were very, very conscious that it wasn't just about looking at epilepsy, but it was looking at the psychosocial context of people's lives. And because that is often the most difficult and challenging piece, and it's also the piece that it may impact on compliance with treatment or even compliance with investigations. The other piece of the clinical aspect that was really important was that they were prioritising, in terms of doing the detailed assessment, because they were doing such a detailed assessment of people and getting to know people, they were in ideal positions to prioritise appointments, to arrange investigations, to do referrals on the spot. And in a lot of cases then they were offsetting other issues happening because they were seeing things very early. The education of the person with epilepsy and the family to have knowledge around epilepsy was critical. But equally, it was also not just about imparting knowledge, because anybody that knows that's engaged in teaching, that it's easy to stand up and think you've done a great job in imparting knowledge. But I think it was about knowledge so that people could get confidence to believe that they could self-care and that they could manage and that they could manage at home. And I think for family members that was important. And when we looked at and when we spoke to family members, especially with children, that was a real important thing, was about getting the confidence to be able to manage and to have confidence that you were going to do the right thing for your child at home. They were also involved in prescribing and titrating medication, doing systematic monitoring and follow-up of people, and coordinating the care pathway. And again, in terms of coordinating the care pathway, the key to that again was that they were knew the person. And the people we spoke to, and all other times they'd say, well, you know, they know me. And you got a real sense that the clinicians knew the people that they were looking after, and knew them beyond, as I said, just their diagnosis, but knew the real context of their lives. The other piece was that they were engaged in, from a clinical aspect, was referral and liaising with the multidisciplinary team to inform clinical decision making with the MDT team. But as I said, the clinical aspect of the role was only made possible as well by the fact that they were highly motivated change agents who were leading and negotiating changes across the disciplines and organisations. And we will look at some of the aspects as we go through. They were developing and expanding services, looking at clinical guidelines, protocols, care pathways, and education programmes for people with epilepsy, for the family and for the wider multidisciplinary team. And I suppose the other piece was that the promotion of evidence-based practice was critical to their role, and hence they were disseminating best evidence, but also translating evidence into usable forms. And I think that's important, that sometimes we can have the best evidence, but sometimes in terms of people understanding it, and I think that the epilepsy nurse specialists were doing a lot in terms of helping family members to understand the evidence. And they were also auditing services against standard operating procedures that had been developed as part of the clinical care programme. So in terms of, I suppose, that was a snapshot of some of the things that they were engaged in from a role perspective. So when we look at the impact, so as a synthesis of the findings would say that they had a positive impact, one, on people with epilepsy, their family members, the multidisciplinary team, because a lot of the times we think about it in just in the context of people with epilepsy in the family, but their impact on the multidisciplinary team, and then their impact at a service level. I suppose the first thing to say is that findings was that they had increased the number and range of services available to people with epilepsy. And of course that meant that they had increased access to epilepsy specialist care, and in some cases were decentralising the services. So here are some of the services that they were providing: the nurse-led clinic, the telephone advisory service, the VNS clinic, the rapid access clinic, the outreach service, and educational fora for people with epilepsy. I suppose if we think about in terms of the telephone advisory line, and I think it was Joan who was making a plea for an extension of the telephone advisory line. I think for the family and people with epilepsy, that this was a really important piece. While it wasn't an emergency service, but it did provide a timely response, it prevented problems escalating, it offered people with epilepsy and their family reassurance in terms of home. They increased the person and the family's confidence to care from home, and in a lot of cases it decreased people's attendance at an emergency department or attendance somewhere else because they were getting a response immediately. I never thought about the telephone advisory line being an outreach to India because we hadn't met anybody. But and again, I think that in itself is a very important thing, that when you realise that people want to travel, and having that confidence that there is somebody there. And I think, and I can't stress how the family members, especially family members with children, emphasise the importance of the telephone advisory line for them. So it wasn't just what was interesting when we did the observation, and when we were out on the observation study, you think of the telephone advisory line as for people with epilepsy and family members. But in fact, when we went in and the clinicians talked to us about it as being for family members and people with epilepsy. And I suppose this is the value of going out into practice to see what happens, because you also see other things. And when we were engaged in the observation, we realised that it wasn't just people with epilepsy and family members that use the telephone advisory line, that the GPs ring in sometimes to look for advice. People that are looking after people in nursing homes ring in to look for advice. So again, it is an educational fora for the multidisciplinary team. In terms of the VNS clinic, at the VNS clinic, epilepsy nurse specialists turned on the devices. They educated people and the family about the vagal nerve stimulation. But as well, when it was decentralised outside, in most cases, people historically had to come to Dublin. And we all think everything happens to happen in Dublin. But once people started to develop these services, the epilepsy nurse specialists started to develop them out. When you met people in the clinics and the family members, a lot they spoke about how it had really changed their lives in terms of decreasing the burden of having to travel. And if we recognise that, a number of people will not be able to drive themselves, and people with intellectual disability may have to need extra supports, and family members may have to take time off, that is a really, really important piece of being able to develop these services outside Dublin. And again, a very interesting piece in terms of knowing people with epilepsy that we saw when was in the observation was because the epilepsy nurse specialists knew people and knew them very, very well. And especially, I think this is something we need, it's not made public enough, is especially for people with intellectual disability who may have had challenges in staying in a queue waiting. That it was really interesting to see how the epilepsy specialist nurses kind of prioritised them very early in the morning. And again, families just thought, you know, it made such a difference to their lives that they were the first seen when they arrived, and they were progressed through the system very, very quickly. The other piece, I suppose, that in terms of the rapid access clinics, the importance of those was that they were offered people an opportunity to be fast-tracked from services into those services, and excuse me, to be seen in a very timely manner. And I suppose the rapid access clinic was used by, we'll say, the GPs may have transferred people in. The clinical nurse specialist may have made a decision from having a phone conversation, but equally people being discharged out of an emergency department into the rapid access clinic. And while you may think that that is a simple thing, I think when I think about it and when we looked at it and when we spoke to the medical people that in it, the important piece of doing that was the fact that they had confidence in the clinic and in the specialists that were running it. And I think that comes back down again to the knowledge base, that it's fine to set up the clinic and to put a clinician into it, but if they don't have the real knowledge base and expertise, then the medical people will not have confidence in us as nurses to do the role. So we may have it, but we may not get the referrals into it. And I think that was very obvious from discussing with the medical people, the confidence they had in the people that were running the rapid access clinic. The other service that they had led on the development in with the multidisciplinary team was an outreach services. And these to people who sometimes in the literature they talk about them as being a neglected group of people. And this was in terms of the intellectual disability services, and they were also doing outreach into the maternity care services and pregnancy, and starting to do some outreach into nursing homes. And again, this was a very important piece, especially for in terms of the intellectual disability services, where people didn't have to travel. In one service at the time, they were piloting, while we think about education as a one-to-one piece, they were also piloting educational fora as a group educational intervention for people. Again, all the time looking at auditing their services to see how best they can increase and make things much more efficient. So that was the first, I suppose, thing in terms of they certainly increased the number and the range of services provided to people, which had knock-on implications. Then in terms of just some of the other findings in relation to the impact on the information provided, this is where we looked at, I would say from a survey point of view, we looked at people who were attending services with epilepsy specialist nurses and then attending services without epilepsy specialist nurses. Now when we were doing this, we did have a concern that we would end up trying to compare apples with oranges, that we might end up with two very different cohorts of people. But when we looked at age, the level of epilepsy, the attendance, and that, and all of the demographics we collected, and we did some analysis statistically across. In fact, we have got nearly a matched cohort in relation to a number of areas. So in terms of the nature of epilepsy, we had asked a number of questions on that. There was 4 questions around the nature of epilepsy, and this is just the mean for the 4 for the little scales we had brought together. And you can see on the epilepsy site, which is that yellow or orange? My ability to decipher colour sometimes isn't good. So on the orange side is the epilepsy nurses, and you can see that in all of the areas that they have a higher mean scores for people's knowledge on the nature of epilepsy, the medical aspects of epilepsy. And we had 9 questions in relation to the medical aspects of epilepsy, the social aspects of epilepsy, the safety aspects of epilepsy, and the advice on anti-epileptic medication and pregnancy. And again, so the epilepsy nurse specialists, people attending, rated the information higher on than people who are attending the non-epilepsy specialist nurses. And I suppose the areas that was, when we looked at it from a statistical point of view, was really the social aspects and the safety aspects of epilepsy. While the scores on the medical aspects of epilepsy are a little bit higher for the epilepsy specialist nurses, when we did more detailed analysis, they didn't come out in terms of statistically significant. And that would be expected because the people in the non-epilepsy sites were also attending and seeing epilepsy specialists, but in terms of medical specialists. In terms of the ESN on the person's involvement in care, we had 5 questions in this area, and it was about their opportunity to ask questions, to discuss their worries, to contribute to being decision making and feelings of being heard. And again, the epilepsy specialist nurses sites come out higher. And the qualitative data certainly added to this, and we have a 300 and something page report that you, and you can read a lot of the data within that. But the people's sense of being involved, being listened to, and being a partnership in the care and in the decision making. The impact of the ESN on coordinating of care. We had 4 questions in this area around care delivered in a planned way, the ease of making appointments. Follow-up was one of our areas, and waiting times. And again, we see that the epilepsy nurse specialist sites come out slightly higher. With qualitative comments, I think one of the things that the people, when we spoke to what they liked about the epilepsy nurse specialist, is while they provided a link between them and the consultants, they often sometimes translated, as they said to us, some of the technical pieces. They reinforced, sometimes in the stuff that they would have heard in the earlier stage of their medical consultation, the epilepsy nurse specialist maybe came back, revisited, reinforced it, went back over it, and again helped people to really understand. I think the other piece that they felt was that the epilepsy nurse specialists were very responsive and gave really good follow-up care. And I think that we also saw that in the observation in terms of the people that may not have attended for an appointment, or that they following up on that. And again, where the specialists, in terms of people that really valued that extra piece of follow-up, was people that were post-surgery. And I mean, that was in one site, we'll say, where the surgery happens, that the post-surgery follow-up, because people went home and they spoke about being really scared and knowing that there was somebody there, or that they could make contact back in with. They spoke about, I suppose, the telephone or line in terms of coordination of care, was that it was a lifeline, because it was of its ease of accessibility, but also because they didn't have to wait till the next appointment. And a lot of us know what it's like to get an appointment and you're not sure whether you should go back earlier or not. And I think from a coordination of care point of view, that was an important piece, because they could ring in and the epilepsy nurse specialist could have a conversation and then maybe even see if they needed to be prioritised. And they valued, I suppose, seeing that the same person that they had that knew them. The impact on epilepsy on persons' health and well-being. We used one scale, which was the quality of life scale, and we saw no differences in the 2 sites. And that may be for a number of reasons. I suppose maybe the scale wasn't sensitive enough to what was happening, or maybe in terms of we need to look at how quality of life is defined within it. But we did ask a question around the impact on health and well-being. And again, the ESN sites are coming out better, and the qualitative data certainly emphasised that. And I think we heard from both Joan and Sinead, the impact on mental health, and that the importance of the impact on mental health. In terms of satisfaction with the support and the emotional support and the practical support, again, this sounds like as if I'm doing a partial political broadcast on behalf of the ESNs. But again, the emotional support and practical support, the scores were higher on both sides. One of the things that we were very interested in was looking at the impact in terms of the comfort and confidence in care. Because if we think about the epilepsy nurse specialist role and the advanced nurse practitioner, one of the things that we have to consider is it acceptable to families and to people with epilepsy? Or are they going to feel that they have been shortchanged because they didn't see Professor Doherty or they didn't see another consultant? And I think that's an important piece. And again, these were some of the questions we asked, whether they felt comfortable talking to the ESN over the other healthcare professional, if they come in terms of sexual health issues, and if they trusted the advice given. And we have, if not slightly higher scores, but in fact, even having them, if we had them the same as their medical colleagues, it would be even good. But we're getting slightly higher scores from people who are attending the epilepsy nurse specialist service versus the non-ESN service. Some of the other outcomes that and I'm just going to briefly go through is, as I said, that they certainly reduced waiting times and attendance at ED and admission rates, and that was very much through their outreach, their telephone advisory services and their rapid access services, and they increased the accessibility to the specialist epilepsy care. One of the areas that I suppose is part of the national programme and is the electronic patient record, and the people that we spoke to, and it wasn't ESNs, but in terms of the multidisciplinary team, emphasised that the nurses were the people that were really, really leading out on getting it implemented and populated. But when we looked at what they were also doing, not just were they in terms of inputting the data into it and encouraging everybody else to input data into the electronic patient record and to use it, but from an observation point of view, when we were out looking, what was very clear was that they were also quality assuring it. They maybe didn't realise it, in terms of, because they were constantly checking to see if the data was correct and if there was a match between the electronic patient record and any of the data that might have been in the hard copy chart. They impacted on the multidisciplinary team, they increased multidisciplinary knowledge of epilepsy based on the best evidence, and that in terms of the stretching out into the nurses that worked on the wards, to the GPs, to practice nurses. They were liaising in with them and engaged in education. They were very much inputting into undergraduate education and developing and inputting into the master's programme, the more advanced nurse practitioners into the master's programme on epilepsy. And I suppose that was maybe what made some of these programmes in terms of epilepsy of a quality, because you had people that had both the knowledge and the clinical experience. There was evidence of them enhancing the communication across the multidisciplinary team and reducing the family burden and increasing the confidence people to care. There was some evidence as well in terms of that they were making efficient use of resources by the fact that they were taking on some of the roles done by the medical people, giving them more time to look after maybe more complex cases. And I suppose this is just a word cloud, I think that's what it's called, of what the people with epilepsy and the family perspective, things that came up in the interviews. And I think that in itself speaks for itself in terms of their empathy, the support and the reassurance. But I think I come back to it that we can have all this empathy, support and reassurance, but if it doesn't come with a knowledge base, then it is, it's niceness as opposed to clinical competence. And I think that we need to bring that compassion and the competence together. And I think we've seen a model where both of those pieces are brought together. From a cost effectiveness point of view, based on some of the data that we had, and Professor Norman was the person that was leading up on this piece of it, seeing I can not able to look after my own money, never mind wonder about anybody else's. What we found in terms of the people with epilepsy who received care from ESNs had the same cost as those treated in non-ESN sites, but maybe experienced some better outcomes in terms of education, satisfaction, knowledge and the management and treatment of epilepsy. But qualitatively, there was other potentials for cost savings where the ESNs took, as I said, on some of the traditional roles under the remit of medical consultants. The telephone and advisory line and the rapid access clinics certainly reduced hospital admissions and ED attendance with cost-saving implications. The outreach services to the ID services, if you think about it, also reduced certain costs because people would have had to healthcare practitioners may have had to travel, and so that's a half a day's time for people to come to bring somebody to a centralised service. So I suppose the conclusion is that they are certainly good value for money, and they improve the experience of people with epilepsy with no change in cost. So we don't know whether we haven't done how much money they saved. So it wasn't without, I suppose, their challenges in terms of that they have a large clinic caseload, and that is certainly a challenge, and that's a challenge as we go forward, because there is a danger that the service demands are now getting to outstrip the resources available, and the concerns about sustainability of the quality of service as you stretch it more. They had a challenge in carving out time for research, and I think there was a challenge in terms of the time for the medical and nursing people to mentor candidate A&Ps at the same time as doing their own roles. There's a challenge I think that we need to think about, and the programs need to think about, is in the single post sites, because if you have only one epilepsy specialist nurse, people have to take annual leave, they may become ill, they may need to take long-term leave for other reasons, and I think it's about having a critical mass of people with this expertise, so that that we don't end up with a gap in service, so that we give a good quality service to families and to people with epilepsy, and then for some reason we have to pull back, and that is the potential for happening in a single post-holding site. And there certainly was, there's room to improve in relation to some of the structural supports offered to people, whether it's the admin support given to them, some of the physical environments that they were working in left a lot to be desired. And I think that that's certainly in terms of, from a hygiene, when we talk about motivation factor, I think we need to really look at some of the physical environments in terms of where we have some of the epilepsy specialist nurses working. I think the other thing in terms of evidence-based practice, and it's a simple thing that we need to resolve, and that is library access. You know, we want people to be able to give care based on the best evidence available. Many of these people had real challenges in trying to get access to the specialist journals. And in some cases we're kind of doing programs and we're getting access because they happen to be doing and registered with the university. But again, I think in going forward that we really need to find a solution that gives advanced nurse practitioners in all disciplines access to the library. So in conclusion, says you last, that I want to say that they were highly skilled, knowledgeable and motivated individuals. They certainly fulfilled the clinical role identified in the National Epilepsy Care programme and went beyond. They added significant to the quality and integration of care for people with epilepsy in Ireland. They were leading change for improvement in epilepsy service delivery, and they certainly were building capacity of MDT for epilepsy care and promoting evidence-based practice at no change in cost. So I suppose as a team we feel that from a recommendation point of view that we do need to continually expand the ESN service nationally, but we need to look at having a critical mass of EN posts in all services so that we don't end up with gaps in it, and that there is start to expand more in terms into women's health, into the intellectual disability, children and adolescents, and I suppose looking at it in the context of mental health and old age. We need to look at some of the deficits in the structural and professional supports for the specialists, and I think that one other thing that needs, as Naomi said, this study was done at a very early stage in the rollout of it, that it needs to be repeated maybe in 5 to 7 years, looking at some of the outcome indicators that we have identified in the study. So I just want to acknowledge that without this study, certainly wouldn't have been done without a lot of people. We had, especially the people with epilepsy and the family members who so willingly gave opinions and commentary and attended focus groups and individual interviews. The ESNs themselves who were so welcoming of us into the sites. You know, stranger turning up that they hadn't met before, wandering around after them. And I have to say that any time I was there, I was certainly welcomed and I learned an awful lot. The members of the multidisciplinary team who took part in it, the directors of nursing and the medical consultants who really facilitated access, and that's both in the ESN sites and the non-ESN sites. There are funders, which is the HRB in Epilepsy Ireland, and especially Peter, he has been really good to me all the way along. Our collaborators, which was Marion. You're going to hear from Idel and Trace, and some of the researchers that were working on the study in terms of helping us do some of the data collection with Sonam, Danica, Olga and Bredin, and the other members of the research team, which were Cecily, Mike Clark, Professor Begley, who's from here, Mike Clark, Professor Charles Norman, Professor Colin Doherty, Ella and Carmel. And then I can't go without saying a very special thank you to Dr. Jarlath Farley, who soldiered beside me on this report all the way through, and to Joan and Sinead this morning for coming along. Thank you.